Okay, welcome everybody. If you are here for the TriNetX Datavant Mortality webinar, you are in the right place. It looks like we're creeping up on 50 plus participants, so we're going to give it another minute or two, and then we will kick off with our panel and discussion. Okay, well, everybody, thank you all for joining us for this webinar on mortality matters. Over the next 45 minutes, we're going to be talking with experts and practitioners from TriNetX and Datavant about the opportunities and challenges in connecting de-identified patient-level EHR data with mortality data to enable research in which mortality is an outcome that matters. My name is Mark Unger, and I head product management at Datavant. I will be your moderator for this session. Before we dive in, we have one quick logistics note. We invite all the audience members to send in questions through the Zoom Q&A function during the presentation. If there's a natural breaking point, we have a question that's relevant to one of the presenters, I may jump in and do some Q&A live. And then of course, we'll have time for Q&A, dedicated Q&A at the end. Okay, so jumping on to our agenda. Our experts will present evidence on what happens when using EHR data standalone versus computing survival curves with additional mortality sources layered on top, and what sort of uplift you can get. And we're going to give you the lay of the land in terms of what different sources of individual level mortality data exist. We'll share some statistics about the coverage of those sources, the concordance across those sources, and more facts on how to work with them. We'll show the uplift that we've seen in real healthcare organizations from layering on this data, and we'll talk through what other types of data can be used in conjunction with EHR mortality data to facilitate research. So we have a fantastic panel here today. I'll provide a brief introduction. Seth Kurantz is the Director of Clinical Sciences and Operations at TriNetX. Seth is an epidemiologist who has advised dozens of life science companies and healthcare organizations in the TriNetX community. Seth's areas of expertise include study design, optimization, cohort identification, and the generation of real-world evidence from EHR, claims, and other real-world data sources. Rick Lilienthal is a Senior Data Operations Manager at TriNetX. Rick works with TriNetX end users in both healthcare and life science to make use of data at the leading edge, from genomic variants to NLP-acquired clinical notes. Maggie Berryman is Vice President of Global Data Engineering at TriNetX. Maggie is responsible for keeping TriNetX's data offerings timely and rich, and she works with stakeholders inside and outside of TriNetX to onboard new data providers and data consumers, and to expand the types and sources of data that TriNetX provides. Serena Gupta is a product manager at Datavant, and Serena has worked closely with all of the mortality data sources that are available through Datavant linkage, and she works on Datavant's compliance and security-related products. So finally, I want to mention that Datavant is a technology company that enables organizations to safely link patient-level data across organizations, and TriNetX is a global network of healthcare organizations and life science companies driving real-world research to accelerate the development of life-saving therapies. So Datavant, the company that I work with, and TriNetX, our friends, have enjoyed a partnership over the last few years in which Datavant's tokenization technology and connectivity products are used within TriNetX's platform. And that's what brought us together here for this co-presentation on mortality data. Okay, and so with introductions to the panel made, we now turn to Seth from TriNetX, who's going to talk us through what happens when you perform analyses with and without supplemental sources of mortality data. So Seth, thank you very much for being here. The floor is yours.
Thanks, Mark, and thanks everyone for joining us today. As Mark said, I'm an epidemiologist here at TriNetX, and I want to kick us off by showing you some examples of research and results that are produced using a linked EHR and external mortality source. So we can go on to the next slide here. To start off, just to level set here, when we're thinking about mortality and analyses of mortality in real-world data and clinical research. Mortality is obviously a very important endpoint for many research questions. We look at mortality in a few different ways. Often we're interested in the absolute risk or the absolute rate of mortality in a population, whether that's simply to describe or benchmark a population or to compare one patient population to another population. We also look at things like survival probability over time and whether the probability of survival changes over follow-up. And then there are, of course, many more advanced modeling and approaches to understanding mortality in a population, including things like Cox proportional hazard models or other time to event modeling. If we go to the next slide. So one of the challenges of looking at mortality in a real world data source is that over time, especially in an electronic medical record data source, we will often lose visibility into the patient's record over time. We might call it loss to follow-up, or from a data analytics perspective, the fact that we are censoring patients when we no longer have information on them. And this can lead to some issues in an analysis. If censoring is differential, it may introduce a bias. Over time, if we start to censor patients and our sample size drops, we're going to increase the variability in our estimates and call into question some of the validity of our analysis. So losing patients and losing information on the outcome of interest in the study is a pretty significant challenge. And the work we can do to minimize that or minimize the effect of it is really important. And there are certainly analytic methods that people fall back on, whether you're weighting populations to take into account censoring, or if you're doing some work from a data perspective, like we're showing here, where we're actually bringing in additional information on patients and filling in some of those missing pieces of information, like mortality endpoints. We can go to the next slide here. So I want to show you some results from the TriNetX platform where we've used linked and unlinked data. So just to orientate people to some of the language I'll be using and some of the language you'll see on the slides. We're using the terms enriched versus unenriched mortality data. And so where you see a cohort of patients where they're coming from an enriched data source, what we're referring to there is a cohort of patients where we've taken their electronic health record and we've linked it to a mortality source, or for that cohort of patients, we've brought in this additional mortality source. So their data is enriched with additional information that you would not see if you were using the EHR data alone. The unenriched data is the same underlying data, just without the link to the mortality information. So a healthcare medical record will often have mortality recorded for some patients, but it bumps up against that challenge of after they leave the hospital, what is happening to them? Do we know whether they're still alive or if they've died? And sometimes we do, and sometimes we do not. And so the enriched data brings in those additional pieces of information around mortality. We can go on to the next slide here. So the major question is, does linking EHR data to other real-world sources of mortality change the analysis? And to go on to the next slide here, the answer is yes, of course it does. Here's an analysis looking at that enriched versus unenriched cohort, a group of patients with acute myeloblastic leukemia, AML, and looking at 5-year overall survival. And you'll see the purplish red color there that over the course of follow-up, having additional mortality data across that follow-up brings that line, the purple line, lower on the graph, meaning that patients, when we are able to link their data, have a lower overall survival over time than patients with unlinked data. And that's due to the fact that we now have more information on these AML patients and can describe a more accurate trend in mortality over the course of follow-up. If we go on to the next slide here. So now looking at a couple of examples where we're comparing cohorts of patients to one another. So we're looking at some absolute comparisons where we're looking at absolute mortality and survival probabilities and comparing them to different cohorts. And we're also looking at relative measures of mortality, so hazard ratios and 95% confidence intervals. In this case, we are comparing stages 1 and 2 pancreatic cancer to stages 3 and 4 pancreatic cancer patients. So this is in purple, stage 1 and 2 is the stage of pancreatic cancer that patients had when they were first diagnosed, and we're comparing them to stage 3 or 4, the stage of cancer they had when they were first diagnosed. So in green, a group of patients who were much further along in the course of the disease at the time of their diagnosis. And we would expect that patients who were diagnosed with pancreatic cancer have a higher risk of death and die sooner over the course of the follow-up than patients who would be diagnosed earlier in the stage of disease. And that's what you're seeing on the results on the left. The results on the left do show that expected trend and support that hypothesis. So the results on the left are coming from that unenriched data source without linked mortality data. And we can see that in the third row there that patients with stage 102 have about an 80% survival probability over around 5 years of follow-up. And that's much higher than patients with stage 3 or 4 pancreatic cancer over about 5 years. They're closer to a 30% probability of survival at that time point. But what we can see when we move over to the results on the right is that the absolute numbers are actually very high compared to what we would probably expect. And when we add in the linked mortality data, our survival probabilities, both in the purple group, the stage 1 to 2, and the green group, stage 3 to 4, decrease substantially, quite dramatically, and are much lower over the course of follow-up. If we go right below those boxes that are shaded in with green and purple, you'll see the hazard ratios, the relative measure of mortality between stage 1 and 2 and stage 3 and 4. And here, actually, we don't see too much of a difference. That when you're looking at relative measures of survival and mortality, actually the story is very similar. You have a much lower probability of death, although it's still quite high. But compared to stage 3 and 4, stage 1 to 2 have a much lower rate of death relative to the higher stages in both the enriched and the unenriched data. If we go to the next slide, this is a very similar story, a very similar setup, and for time I won't go into too much detail here. But we're doing the same analysis now, just in a different patient population, where we were looking at an oncology patient population with a relatively small number of patients with pancreatic cancer. Here we're looking at a much more common population, patients with end-stage renal disease with and without atrial fibrillation. And all the differences between the cohorts aren't as dramatic. We can still see that it's the same story across the enriched and the unenriched data, that patients, when we bring in additional mortality data, we really see a very substantial difference in the absolute measures of survival. Although relatively, it's telling us the same story, that patients with AFib are more likely to die over a follow-up time period than patients without AFib.
Hey, Seth, thank you very much. We have one question here, which I hope that you will be able to understand better than I. So when conducting these sort of survival analyses, can you control for disease-specific causes of death or competing risks?
Sure. That's a great question. So cause-specific death and the reasons for death are going to vary by data set. Not all data sets will have a variable or will characterize the cause of death in the data. One of the nice things about linking a mortality source with an EHR is you do see sort of the rich clinical characteristics of the patients, maybe the complexities of their care, the comorbidities, other clinical events that are occurring around the time of death. And one of the things we know is that death is rarely caused by a single event. And so with the rich clinical EHR data, you're able to describe what's really happening at the time the patient died, with the linkage to the external mortality source. And then, of course, the question around competing risks. Not all questions we're asking in clinical science have to do directly with mortality. We might be looking at acute outcomes like an MI or a stroke, or we might be looking at questions around remission or relapse. And of course, mortality is an important data point in those analyses, as someone who dies is very different than someone who has not relapsed for a disease. And so be able to understand the competing risks for your outcomes of interest, of which death is often a very significant competing risk, is important.
Got it. Thanks, Seth. So you're saying the EHR can provide additional information as to what might be happening when there is a death that's captured either directly or through these other sources that you're bringing on top. Seth, let me ask one follow-up question here. So the statistics here are pretty clear that the enriched data lowers the survival curves. And in fact, there's more patients that have deceased at any point in time. What are the sort of decisions or outcomes that you see your clients making when they get these enhanced data sets? Like what changes in how they would provide care or make decisions? What are the sort of outcomes from that?
Yeah, so it certainly expands the types of questions you can ask of the data, but it can also be used in planning, in thinking about healthcare resource use, as well as obviously communication with patients, and being able to communicate quality information and clear information to your patient population. So I think it has a wide range of impacts across those areas.
Great. Okay, thank you very much, Seth. So with that, we will now turn to Serena from Datavant, who's going to give us a lay of the land in terms of what mortality sources exist and how to think about working with them. So Serena, thank you for being here, and the floor is now yours.
Thanks, Mark. So just to start off, our company Datavant isn't a data source. Our role in general is to make disparate data sources linkable on behalf of the data owners and generally help those data owners get connected with partners who need, in this case, mortality data. Next slide. The data sources we work with in our ecosystem are from the government. They source data from online and newspaper obituaries, from medical claims data, and we're always finding new partners to join. And the mortality data available today covers, when compared against the CDC, around 75% of US deaths. And that coverage is representative of the last 10, 20 years, but the data goes back even further. So here's a breakdown of the coverage per source in more detail. And the numbers on this page are for February 2020, but are similar across other months and years. And the main thing to notice here is that no source by itself has adequate coverage. And where you're getting the most value is when you're able to link all those data sets together and use them as a joint mortality data source. So diving a little bit deeper, on this page, you can see a breakdown of the attributes for each type of source. And in particular, I want to call out a couple things. So for a government source, it has the highest historical coverage going back to the 1800s. The claims data we work with has gender available, which enables higher precision matching when you're looking to match the mortality data with your own data. And we also have commercial obituary data, which is very low latency. And so you're able to kind of immediately look at new deaths and use that in your analysis. And, the data isn't perfect, as, probably many of the people who are here are familiar with when working with healthcare data. And in particular, we found that systematically some sources mark, for example, the 1st as the day of death or January as the month of death when the data is missing. And so we advise our recipients of the data to normalize on that, or, group deaths by weeks or months instead of relying on days. Additionally, some of the sources are missing date of birth and date of death. It's, around 10% of the records. And, when we're talking about the coverage and the numbers in the deck today, we're not actually including those records because we found most people don't find the data useful without those records, or without like the date of birth or without the date of death. And lastly, the only source that's able to provide us social security number is from the government. And social security number is an important field for matching, but it's also not always very common amongst other people's data sets. And so we generally anyways recommend people use a matching logic that's based on name, date of birth, and gender. So when validating a new mortality source who we're partnering with and who's joining the Datavant ecosystem, it's really valuable for us to bring in a source who's bringing in net new reported deaths. But it's also an important metric to see that the new source has overlapping mortality records with the existing sources in our ecosystem and network, since that validates that the new source isn't just making up records. And here you can see for a particular data type, the percent of individuals in that data type that are also seen in another data set over February in different years. And it's around 50, it's over 50% for most sources, which is a really good sign. Next slide. Another attribute we look at is geographic distribution of the data. And I recognize this might be a little bit small to see, but here you can see that the number of records available per state in 2019. And the distribution is pretty similar amongst our sources, where the commercial obituaries are just many more. Lastly, one of the things we look at and we graph is the percentage of deaths occurring in a particular state for a particular data type against the percent of the US population in that state. And the percentage of deaths in a state won't directly match the US population, since some states will see a higher death rate or might see a lower death rate. But you can see that the distribution is roughly similar, which is again a good indicator on the quality of the sources. I'll now pass it back to Mark.
Great. Thank you, Serena. So a lot of information in there on these specific sources. I do have one quick question for you, Serena. So you mentioned that some of the sources are providing name, date of birth, and even social security number with respect to the government. How does that data actually get made linkable or de-identified for use in connection with EHR data?
Yeah, that's a great question. So part of what Datavant does is we provide these pseudo identifiers, something we call Datavant tokens. And so we take that identifiable data like social security number, date of birth, et cetera. We replace it with these Datavant tokens. And then what we're able to do is make two different data sets, the mortality data sources, as well as your own EHR system, linkable using those tokens. And since these tokens don't actually have the, your actual first name, they're pseudo identifiers, you're able to connect the data together in a de-identified manner.
Got it. And we do have one question from the audience about what a commercial obituary data source is. Is this funeral homes and newspapers? Can you speak to that question a little bit?
Yeah, that's a good question. Yeah, that's exactly right. When we're referring to the commercial obituaries, we're referring to any mortality data that's sourced from, for example, funeral homes, newspaper obituaries, online obituaries, anything kind of similar to that.
Got it. And one final question for this section related to the metrics for each source. There was somebody's asking about the lag in reporting. So I think down here you had latency, and the question was, You noted how many of the deaths are reported the next week. How long does it take for the death data to become complete from each source, or is there a moment where it becomes complete?
Yeah, that's a good question. So the 20K, let me start with the 20K deaths reported next week, because I know that maybe is a confusing metric. What that means is when we say 20K deaths reported next week, that means if all the deaths ever reported in that mortality source, for say people who died in like June 1st to June 7th, we would basically report the next week, June 14th, 20K deaths. So there's like a 2-week lag there. And in general, what we see is that I would say like something like 90% of the deaths are reported within the first 3 months or after 3 months have elapsed since that date of death. And so when we talk to our different recipients, we generally advise them to kind of wait for around 90 days before they kind of start their analysis.
Perfect. Okay, Serena, thank you very much for that rundown. So next, we're going to turn to Maggie and Rick from TriNetX, who are going to talk us through how to bring all of this together in practice. So Rick and Maggie, thank you very much for joining us today.
Thank you, Mark. As you've heard from the other speakers, there is a really well-documented dearth of mortality data when it comes to many clinical research data sets. But it's not, even though it's been well documented and known for many years, it's not an incredibly easy problem to solve. And so that's why the partnership with Datavant and our ability to continually increase the mortality data sources is so important to us. And Rick is going to walk you through what this looks like from the individual hospital perspective and the implementation perspective.
Thanks, Maggie. So here at TriNetX, through our work with Datavant, we've already linked many TriNetX healthcare organization partners with mortality sources outside of their own EHR. Below, you can see a bar graph of an anonymous sample of 15 healthcare organizations and the results of linking mortality data, each bar representing a specific healthcare organization. The dark blue segments of each bar represent external mortality sources, and the light blue segments represent their own EHR mortality data. In our work with our TriNetX members, we've seen a median of 3 times as much mortality data when comparing before and after linking, with some HCOs showing as much as 12 times more death data. Next slide, please. So this slide shows what linking looks like from an architecture and process perspective. In step 1, the healthcare organization will create their own patient file, which can be fed into TriNetX key generator, where de-identified keys will be generated for each patient. And then these de-identified keys that have absolutely no PHI attached to ensure privacy protection are sent to the TriNetX virtual cloud. And once in the cloud, the de-identified TriNetX keys are matched and deduplicated with the de-identified Datavant keys and the additional Datavant mortality data. And then this data is fed back to the healthcare's TriNetX appliance and made available to their researchers in the TriNetX platform through a newly created Enriched network. Next slide. Of course, one of the most frequent questions we're asked is how much effort is needed to complete a linking project. The resources required from the healthcare organization side is very light. Majority of the effort is dedicated to the actual presenting of the topic to appropriate personnel and any required governance, review, and approval that might be necessary. From a technical perspective, there is only about an hour's worth of work, which includes the installing and configuring of the token generation software, the generation of the patient list per a guidance document that we can provide to you, and the producing of the token file, which then can be transferred to the TriNetX appliance or the hosted solution. So if any healthcare organizations are interested in pursuing a linking project, we suggest reaching out to your TriNetX account manager, and they can work with you to set up meetings to discuss next steps.
Great. So Rick, one question coming in from the audience that I think will be relevant for you, and if not, you can pass the baton. How do you resolve date mismatches for a given patient when you're doing the deduplication and bringing those sources together?
I can take that question, Mark. And I think Serena touched on one of the aspects of it, which is some of these raw data sources don't have accurate enough data to generate the most deterministic link. So there are cases, we've seen plenty of those where we do get mismatched dates. I think it's a case-by-case problem that we look at, depending on the variety of sources that we're using with the particular HCO. State registries are a source outside of our collaboration with Datavant. That's an example of that. And I think the blanket statement that we can say is that EMR data and that sourced directly from the EMR is preferential, and then we can make some other determinations depending on the individual sources.
Got it. One more question related to this part of the process from the audience. What % of the mortality data is actually linkable to an EHR patient or the EHR data? Do you have those statistics?
What % is actually linkable? And we've actually seen wide variation across individual HCOs. We've done some additional analysis to kind of understand the percentage of patients within, say, a given state or a given geography, a particular HCO sort of cares for or interacts with, and compare that to the and the death data that they have when we combine all of these sources, and compare that to what percentage of the state deaths they have. So, and again, it varies. It's about 10% is what we've seen.
Got it. Okay. One final question here for your section that I think I'll jump back up here for. I think there was a question on, are the results in connecting the enrichment curves, are those variable across healthcare organizations, or are they the same? And I think this graph, for me at least, has decided to go fuzzy. So if other people are seeing this as fuzzy, we apologize. But I think this graph speaks to that. So there was a audience question on that. So can you talk about the consistency of the changes in those enrichment curves across healthcare organizations when they go through this process?
Yeah, and you're right. This graph tells the story that it's highly variant, and that is due to multiple factors, right? There might be independent other sources that are being utilized at a particular organization, and so the augmentation of what this collaboration brings will have varying effect according to what other sources they already have access to. So it's highly variant. And as Serena mentioned, and I mentioned previously, the idea is that this is not static, right? That we continue to try to build out this mortality data asset to really get to a completeness that is the best that we can do.
Great. Okay, so thank you, Rick. Thank you, Maggie. The last section we have here before we turn to open Q&A is Serena, who's going to talk through the value and importance of connecting additional data sets in with EHR data and mortality data and what can come from that. So Serena, back to you.
Thanks, Mark. So our ecosystem's mortality data has been made available as part of a free database for COVID-19 research. And in one of the studies that was published in The Economist, the researchers combined mortality data with medical claims data to create a model that assessed your risk of dying from COVID based on your sex, age, and underlying medical conditions. And what they found was that death rates mostly depend on age, whereas comorbidities sharply raise chances of hospitalization in young people. And this model is actually live on the Economist website, and you can type in your attribute and it'll spit out your risk. Another interesting study that we're kind of seeing in our data ecosystem is the interest and need to link mortality data in rare disease oncology studies, where mortality is often a key endpoint being looked at in the trial. And Seth talked a little bit about this earlier with TriNetX. And what we found is, unless a patient dies in a hospital bed, mortality may be missing from the study. So being able to augment the records to see if a patient died, when they died, and from what is critical. I'll pass it over to Maggie now.
Thank you, Serena. And can you forward, Mark, to the next slide?
Yeah.
And so we kind of wanted to end this segment, certainly circling back on the importance of the mortality data and how that will enable research and additional outcomes analysis. But we also wanted to talk a little bit about the greater data journey and always working for the deepest and richest data. And that's a core mission of TriNetX. So this here is just a little stepwise view of the evolution that we ourselves have undertaken, but that we see across the industry. That we started with a base of data that is the electronic health record. We folded in molecular genomics and cancer registry data. We are layering on top of that data that we're able to extract and parse out from unstructured text. And then we've, as our partnership with Datavant has evolved, we've been able to link in claims data as well as the mortality data, but the journey doesn't end there. We're excited about the other future possibilities of linking in registry data, chart review data, additional specialty EMRs, and the list goes on and on. And that's part of the important aspect of being able to have these completely de-identified, privacy protecting patient linkages across data sources. Back to you, Mark.
Okay, well, thank you very much to the whole panel for being here. Thank you for walking us through all that content. We have a bit of time here for a couple questions. So audience members, please feel free to fire up the Q&A, send more in. We'll get through as many as we can over the next 5 or 10 minutes, and then we'll follow up with questions that we weren't able to answer live afterwards. So I will jump in, and I see one here about the National Death Index. They're surprised that the National Death Index is incomplete. So Serena, maybe I can throw it back to you. And can you talk about, when you mentioned the government sources, what are those government sources? Is that the National Death Index or the NDI, and how does it compare?
Yeah. So when we're talking about the government, we're talking about data sourced from the Social Security Administration. Datavant's mortality system sources today don't include the NDI. And for a little bit of context around the NDI, if you're not familiar with it, it's from the CDC. It's the gold standard data set in terms of accuracy and coverage, and virtually covers all the deaths in the U.S. But there's a variety of factors that make it hard to work with. So, for example, the timeliness of the NDI, it's updated annually, so 11 months after the end of the year. So it's sometimes not actually usable in studies if you want to do something that's a little bit more timely. Additionally, the NDI is only made available for investigators who are looking into public health and medical studies. And so it might not actually, your use cases might not make it available to you. And then lastly, the cost of it is around, like, I think $350 service charge. And it's going to cost a lot. And also just the amount of time that it'll take per record is longer.
Got it. Thanks, Rita. So you mentioned pricing, and maybe I can ask, how should our audience think about pricing for the whole set of sources that you mentioned here? If they wanted to work with that sort of data, how does the pricing work?
Yeah, that's a great question. So the pricing will vary based off of your use case, organization, the sources you want to subscribe to. And, we're happy to provide you specific quotes after. Just like ballpark estimates for academic research, the pricing is typically tens of thousands of dollars per year. And for life science and payer use cases, it's in the low hundreds of thousands per year for all the sources. And what we're providing is the entire data set, and you can kind of do whatever you want with those records.
Great. And anything to add on the TriNetX side with respect to pricing or access to the tools and analytics that you create through the enriched mortality data?
Yeah, I would just add on that, TriNetX as an offering to our HCOs and our industry partners, we license the data so that there isn't any end user fees associated with having this data.
Great. Okay, we have a classic question here. Do you have cause of death in the mortality data? So Seth, maybe that's for you. I think you got closest to that in the beginning when you were talking through some of the EHR data and how that might give additional signals. But can you answer that question?
Absolutely, and I don't want to speak for what's in the data sources from Datavant. So please, Serena, correct me if I'm wrong. We don't bring in and surface a variable cause of death directly within the TriNetX data set, whether it's there or not. In many cases, there isn't one when it's coming from a healthcare organization, or the fill rate's fairly low. But the linkage to the clinical components of the EHR do allow you to see what types of care the patient's receiving. And that's often a challenge, even researchers who are relying on a cause of death variable. If there's one element listed as the cause of death, that's often not sufficient to really characterize what's happening at the time of the death and may not actually describe the full picture of what's happening from a clinical perspective. And so having the EHR data really fills out that story.
Got it. Serena, anything else to add from your perspective in working with the sources directly? And thank you, Seth.
Yeah, just to add on to what Seth said, right now we don't have cause of death within our ecosystem, but we've recently found a new mortality partner who we're validating and working with, who does have that field, and we're keen on finding new sources who do have that field, since we know that it would be super useful for the different recipients and the different types of studies that people are doing. So I guess this is to say we don't have it yet, hopefully soon to come.
Got it. Okay, I think we have time for two more questions. This next one here, I think, will be for the TriNetX folks. Does the enrichment of mortality data apply to all of the networks within the TriNetX overall network, such as the research EHR network versus the Diamond Claims Data Network? Can the TriNetX folks answer that?
I will take that, and then Seth and Rick, you can fill in. Yeah, we want this data to be part of all of our networks. We think it's a crucial piece of supporting the research. So yes, it's the research network, any of the DataWorks networks, also any of the ones that we have with claims.
Great. Okay, last question here. Can a hospital get an estimate of how much it can gain in mortality data before getting into the project with working with TriNetX or working with Datavant? That is, can it understand how much it can benefit from linking and enrichment?
Yeah,
maybe start with TriNetX.
I was going to say we welcome that type of exercise with each of our healthcare organizations. That we can do an overlap analysis with simply the tokens. That's the one piece that we need to perform that overlap analysis, but are happy to do so.
Great. Serena, anything else you would add to that?
No, just, I mean, similarly, if you're working directly with Datavant, like Maggie said, we just need the tokenized version of your data to run overlaps. And we're happy to do that on our system before, figuring out if you want to license the data or not.
Yeah, and just one clarifying point, by the tokens, we mean, right, just the de-identified tokens themselves that doesn't need to be attached to any other data elements. That's sufficient for us to do the overlap analysis.
And so no PII, personally identifiable information.
Nothing or any other clinical facts. Yeah,
any
need to be exchanged, correct.
Great. Okay, well, thank you again very much for being here. Thank you to the audience. Thank you to the panelists. Thank you for answering all those questions. I do see that there's a couple other questions that we didn't get to. For those of you who submitted them, we have a record. We'll follow up with you shortly. And for others out there who are thinking, hey, maybe you want to learn more about either of these offerings or how mortality data can help you, we'd love to hear from you. Email's here on the screen, so please jot this down quickly. I'll pause here for a second and feel free to follow up with us. And we'd love to set up a follow-up. So again, thank you to the panelists and thank you to the audience for spending the morning with us here. And with that, I think we'll come to a close.